Good deal. Still water?
Yes, we're back.
Okay, awesome. And I have lecture capture on this time with way less delay. So, nursing process. Okay, so regardless of cause and symptom presentation, your treatment is going to be very similar for most of these people. So, what are we going to assess? We want to look at their memory for safety issues. We want to see what kind of home care they've got. We want to assess bowel and bladder function, continence, how that's affecting their family. Nutrition can be an issue. We'll talk more about nutritional interventions, but these people can often be in constant motion, basically. You know, they sit down, but then they want to get back up and do it. You know, I mean, they can't remember that they just sat down, so they're in constant motion, and they often forget to eat, even when they're still capable of meal preparation. Communication can be an issue. When I assess what their schedule is, we'll talk later about that sometimes like creating kind of a detailed, semi-detailed daily schedule for them can be kind of a comfort to them, and keeping like a calm, consistent routine can help too. Assess their self-care. Are they still taking care of themselves? Are there people that can remind them to do their ADLs, help them do their ADLs? Strengths and weaknesses that can contribute to their care. Plan, of course, is goal setting, and then everything else kind of falls depending on what part of the process we're dealing with. Interventions are going to be based on what their nursing problems are, and our evaluations are going to be based on our interventions. So, moving forward, I have been bad and I haven't asked any questions. Stillwater, your client who is in stage 5 of Alzheimer's disease is asking what time her husband, who has been deceased for approximately 6 years, will be coming to visit today. What is your best response to your client? What do you want to say if you're the nurse?
Tell me about your husband.
Okay, that's good. Do we want to tell her that her husband's dead?
No.
Why don't we want to tell her that?
She'll forget.
What?
She'll forget again.
She's going to forget, exactly. We're going to have to tell her constantly, and she's going to grieve over and over and over, and that's unnecessary, basically. So there's just no reason for us to go down that. So that brings us to kind of our next slide. Thank you, guys. So, nurse-client relationship. We've got some options here. We can use deception and little white lies, or we can use the technique called validation. So, we love as nurses to be the most trusted profession. We've been the most trusted profession for, 18, 20 years? I don't remember, like that study just came out recently. Yeah. So, but is that always the most beneficial for our client to be that total honesty and these people who are going to live in the moment? And how can we maintain our honesty and still, not harm our clients? So, validation approach offers us a way to avoid the little white lies, but still benefit our client. Much like what we talked about when we were dealing with hallucinations and delusions, we do not want to insist an unpleasant reality, such as the death of a family member, on our client over and over and over again. But we do want to look behind that for the themes, the feelings, and the losses that the client is feeling. So when they want their husband to come visit, what can we do? What is it they really want behind that need when they're asking for their husband? Because we know that it's not going to happen if he's deceased. We need to find out what is the feeling or need that they have behind that, and how can we help with the feeling or need that's behind it. So ask questions, focus on who, what, when, where, how. Do not use why questioning for them. So you don't want to directly come out and say, why do you want your husband to be here? You want to ask questions that kind of get you around that. And what she said is a good one. It's a very good open-ended kind of discussion prompt. Tell me more about your husband. Get into those feelings and what it is your client needs behind those things that you can't do for them necessarily. So let's talk about communication strategies. We kind of talked about this already, and I think this is one of the most important slides in dealing with your clients with dementia. As their disease progresses, they live entirely in the moment. There is no past for these clients. There is no future. There's just what's going on right that moment. And I think the more we can keep that in mind, it helps us be patient and gives us perspective in dealing with these clients, because it can be frustrating to tell them the same thing over and over, to deal with the same behavior over and over and over. If they're hollering for their mom over and over and over, and their mom's been gone for a very long time, and but what is the emotion behind that? What do they need when they're hollering for their mom over and over, and how can we help deal with the loss that's behind the actual behavior? What other strategies can we use? We want to be pleasant, kind, and use eye contact. Remember, these clients are going to become less and less verbal, so nonverbal, the way we interact with them non-verbally is highly important. We want to validate their emotional state, regardless of whether the exact facts being stated are correct or not. So look for those feelings. We want to offer our presence, offer to stay with a client who's upset. Remember that this is their only moment in time right now, so we don't want that to be a moment of loneliness. We're going to try to provide some companionship for them when we can. We want to keep subjects positive. You're not going to make any progress or work through any difficult topics with these clients because they can only live in the moment. So we want to just avoid, there's no reason to delve into unpleasant topics with clients in this situation. We want to avoid jokes, sarcasm, and metaphors. So many of these clients have lost the ability to think abstractly. They only think very concretely. So they can only think about any kind of joke or sarcastic comment in a very concrete sense. On the same concept, we want to be careful how we communicate with others in front of them. What maybe just be kind of a debate is going to be an upsetting argument to them, basically. Like they're going to read those nonverbal behaviors in that tone of voice and maybe take it for what it really is. So we want to keep that kind of calm environment around them. Short sentences like we talked about and step-by-step instructions. They can't maintain that information in their active processing for that long. So very short instructions. Don't rush the clients or finish sentences for them. Always approach them from the front. They may also have hearing and visual impairments, and the client may not remember from moment to moment who's in the room. So if you walk up behind them, you may startle them even if you've been in the room for an extended period of time. Limit conversations. So once again, because they're not going to be able to process complex stimuli, basically, so if there are a lot of conversations going on in the same room, they're not going to be able to figure out which stimuli they need to attend to. So you want to just kind of have one conversation at a time, talking directly to them. Scheduling strategies. A calm, predictable, structured schedule is going to work better for these clients. You might want to give them a few choices, give them a little bit of choice in their care, but not a whole ton of choices to choose from. You want your activities for them to be client-centered. Once again, there's no delayed gratification coming here. So, it's not like you can give them a yucky activity now in exchange for a better activity later, because they're not going to remember that what they're going to be doing, what they're supposed to do later. One activity at a time also. Try to keep those things simple. If they're in a group experience, one subject at a time. In all the areas in caring for them, you're thinking calm, simple, positive experiences in the here and now. Nutritionally speaking, as clients decline functionally, nutritional intake can be a major hurdle. They may forget to eat or struggle to eat due to their physical declines. You're going to tailor the needs to the individual. So clients who are in constant motion are going to need nutrient-dense finger foods that they can carry with them. Provide favorite foods to them, as to their enjoyment of the here and now, and can also enhance their intake. You may need to use liquid supplements to improve their intake, especially as their physical abilities decline. You may need to consult speech pathology for a swallow study if you notice that they're having swallowing difficulties to maintain their nutrition. Toileting, like we talked about, is also a major issue. Increases in incontinence and toileting can often lead families to be unable to continue to care for their loved one in the home. So first and foremost, you always want to eliminate the possibility of an illness such as UTI or C. diff that's contributing to the incontinence and toileting issues. You want to give meticulous attention to keeping their perineal areas clean. And we want to offer them toileting every 2 hours. This is helpful at home in preventing incontinence. It's also helpful to us in the hospital in preventing falls, because those clients who are confused will try to climb out of bed and go to the bathroom when they feel that urge to go to the bathroom sometimes. Whereas if we can keep them going every 2 hours and they're never kind of getting to that desperate point, they won't try to get out of bed without us as much. Monitoring strategies is the next one. So following incontinence, this is the other primary reason that families have to seek inpatient care for their loved ones, is that they wander. It can be goal-oriented, like they're trying to leave a certain area. We see that sometimes in the nursing homes, depending on what nursing home we're in, where we have clients who are trying to go to the doors repeatedly. It can also be just aimless movement, like they just, they're agitated and they're restless and they just want to move all the time. Wandering paths are one thing that can be incorporated into a facility to help decrease anxiety and irritability on these clients, kind of give them a place where they can walk. Continuous paths with no dead ends are the best. They can also decorate windows and artwork to enhance that experience. We can also camouflage exits for those who are goal-oriented wanderers, so if we just make it look like it's a part of the wall or something like that. Stop signs can work for some clients, but for people who are goal-oriented at getting outside, the stop sign is usually not gonna stop them. Your book talks about discouraging, like, sometimes people will try to paint like a hole or like a dark area in front of an exit to try to keep the person from going to the exit. The problem is that in an emergency situation, you may have trouble getting them to actually exit a facility because you've created that kind of barrier there. There are some other, like out in the community, Alzheimer's, there's an Alzheimer's project with law enforcement called Safe Return, so they can wear kind of an armband that will help. Medic alert bracelets are an option. Some clients, you can add like the ICE entry, like an in case of emergency entry to their cell phone if their client who still carries a cell phone. I just the other day saw an article about GPS footwear. So basically, like, you know, you could get footwear that even if they didn't carry a phone would track where they were. It does happen that clients do wander and pass away due to elements and other things like that when they wander out of facilities and wander away from homes. Pharmacological therapy. So these clients may be taking multiple meds to deal with both the dementia and the effects of the disorder. Meds for dementia themselves are generally FDA approved for that, but then we also sometimes use other meds off-label to help with the disorder as well. Nurses need to be diligent with this population about their multiple medications, that they're going to have trouble remembering to take them, things like that. So medications can be a major issue for these clients. There are 6 meds that are FDA approved for Alzheimer's treatment. The first 4 on your list, in one way or another, combat acetylcholine deficiency. That is often an issue for clients with Alzheimer's. They all boost those acetylcholine levels by inhibiting the metabolism of the neurotransmitter, so they don't actually increase how much is produced or released. They just change how quickly it breaks down. Once again, does not slow the disease progression, it simply decreases the symptoms. So we're going to decrease the symptoms, and we've seen some clients, and I don't even remember where, who had been on their med for about 3 years and had seen no progression at all in their symptoms. And it was somebody who was relatively young and still aware, aware she had the disorder, took her meds regularly, and her symptoms had not gotten any worse. Now, the problem is the disease is still progressing in the background, meaning like that. So you're treating the symptoms, but when they stop taking the medication, they will take a sudden downturn, basically, because their disease has continued to get worse, even though they're not showing that. Most of your medicines for Alzheimer's need to be given with food to minimize the GI side effects. That first one, Tacrin, specifically causes liver failure, or is toxic sometimes, so it's rarely used, and you need to be looking at liver function if your client is on that. Donepezil, which is your second one there, is the prototype for the cholinesterase inhibitors. It has high risk for fainting and for GI bleed. Ribostygmir is your third one there. It can come in patch form, has a high risk for dizziness. You need to rotate sites on those clients and not use the same site for 14 days. So if you use the site, you shouldn't use that site again for 2 weeks. I'm assuming a day, but that I was thinking as I was reading that I don't actually know that off the top of my head, so I can look it up. Yeah, I know, that's what I thought too. That's a pretty wide rotation of spots. Let's see the one on there. Oh, galantamine has a risk of increased mortality in those with mild cognitive impairment. So it has kind of a lot of stuff that you want them to report. You're going to watch their blood pressure, watch for EKG changes, and that's that fourth one that starts with a G. Here are the things you want your clients to report for that medicine. If they have a significant weight loss, if they're having cardiac symptoms, such as palpitations or chest pain, if they're having fainting episodes, dark stools, in urinary if they're having blood in their urine or retaining urine. That particular medicine, if they miss a few days of it, which is something that might commonly happen in this population, they need to be retitrated from the lowest dose. So they need to not just jump back on it. They need to go back to their original dose and titrate back up to where they were.
She should say a few, and she should go specifically.
She said if you miss a few.
Memantine is your next one. It is the only approved med that does not interfere with acetylcholine breakdown. It actually acts on another neurotransmitter called glutamate. And that's how it decreases symptoms. Once again, it's not a cure, it's just decreasing symptoms. It tends to have more so those ones that we talked about in the beginning tend to have more of a cognitive effect, like an effect on cognition. This one deals better with the behavioral and functional issues that come along with it. So those emotional changes and trouble with ADLs and things like that. Since it works in a totally different way, it can be used in conjunction with the acetylcholine ones, the top four. So you can use those together. And that's what that last one on your list, Manzarek, is a combination. So these meds are a little bit hard for families because the improvements are subtle. Starting these meds are not going to give them back any of the decline that their person has already lost. That's why it's important that we identify these clients early. So they're not going to get back what they've lost on these meds. They're going to have very subtle improvements that are barely maybe noticeable. The real advantage is that they're going to not show symptom decline while they're on the medication as much. I mean, they're still eventually going to decline. It doesn't change the long-term end result. And so families sometimes will have mixed feelings about these meds because they're expensive and they don't change the end result. They also, if the family's already at a difficult point with their loved one where they're dealing with incontinence and they're dealing with laundering, it may feel more like it's extending the time to an inevitable result when they've already kind of lost the person that they loved. So just keeping in mind that they're not, there are medications, but they work better if we catch them early. They're not a fix-all situation once people have really begun to decline. Management of milieu for these people. If time permits in this lecture, we're going to hit some more milieu stuff on chapter 20 that's kind of applicable to all psych, but for now, specific to Alzheimer's, we want to ensure their comfort as much as we can. Remember, they're living in the now, so we want the lighting to be pleasant for them, take them outdoors, let them enjoy the outdoors when you can, control the room temperature to their comfort. You want to eliminate as much of noise, such as like having the TV on all the time, all those things, once again, calm, peaceful. Try to match up personalities of roommates and personal preferences when you can. What can we use as memory aids? There's kind of just a little list from your book here. In the initial phases, while they can still kind of read large print things, picture instructions can help them with like new equipment. So let's say, okay, I want to say I'm not super old, but like I struggle with my TV remotes already. So like if they, if their TV breaks and they have to get a new TV remote, it's going to be hard for them to know how to operate that new remote because they can't make those new memories. And so like sometimes picture instructions or, even like, if a daughter, has a picture of the remote and can talk her family member through it. But little things like that will allow them to be independent longer, how to operate their new microwave or things like that. So photo instructions are helpful to them. We can also use pictures with pills. Showing them a picture of which pill they need to take at what time of day can help them stay in their homes a little longer. Pill boxes that are broken down by days, even different times of days. It can also be helpful to set like an alarm on their phone if they're still carrying a cell phone that will kind of remind them when it's time to take their medicines, or a lot of times a family member will call them and remind them which medicines they need to take right now. Sorry, I'm trying to cough. And also, we talked about a little bit, large print daily schedule can help them kind of just maintain a sense of control over their life for as long as possible. Okay, activity for today, we'll give you, 10 minutes. So our activity for today, we've talked a lot about the fact that family members of clients with dementia can have a lot of exhaustion from trying to care for their clients. They're also having anticipatory grieving. The clients are emotional. They've changed. They're not the loved one they knew. And so they're starting to grieve even while they're trying in this kind of high care environment where they're trying to take really good care of this person. And it's frustrating for them. They haven't had the benefit of these classes for years of how to talk to and deal with clients who are in that kind of decline. So they really need community resources. So that's your in-class assignment for today. I want you can write them down and turn them in. Let's do that just on a scrap of paper. I don't care what you do it on. You need 2 community resources that are specific to your area. So those answers are going to be different for 2 sites, and 2 online resources that would be helpful to clients or families with Alzheimer's. And here's my one thing. Each site, whoever comes up with, I don't know how to word this because it's not necessarily the most creative, but really the best unique resource. So don't just give me, is going to get a prize. So one person from each side is going to get a small prize who comes up with the very best resource from your community that could help your Alzheimer's client. Now again, if you're from Tonkawa, you're going to have to expand. I mean your area. It doesn't have to be a Tonkawa resource because that's going to be hard to get one. Yeah, here actually there's a slide. Let me switch slides. Does that help? So dig in a little bit and see what you can find online in your community. We'll do 15 minutes. How's that?
Are we supposed to do this as a group or alone?